maybe I can ask Richard and Andrew to come back up. So we're going to open this up now to the audience. You've heard 3 fantastic talks, and if you'd like to put your hand up, if anyone's got a question, maybe while you were thinking of them. Keith, as you're leaving, kind of got more of a free hand. If you could be Secretary of State for a day, what's the one thing you would do to make healthcare safer in England or the United Kingdom? What's the one thing you would?
I just have to stick at one, do I?
You can have as many as you like.
No, I think what I would really like to see is the mandating of safety management systems. So I'm talking about a systematic and proactive approach to safety, so that it's not reactive. People have thought about these things. It's part of the everyday world, and it puts it on more of an equal footing at board level then with finances and all the other bits and pieces. Every airline in most of the Western world has to have a safety management system, and I think it gives assurance, and it stops it, or it takes it from the world. At the moment, I think it sometimes is left to the enthusiasm of the leaders, the enthusiasm of some of the experts, and if you don't have those, it falls down to the side somewhere. So I think it needs to be forced in at that level.
Okay. Anybody in the audience got any questions for? Yes, please. There's a roving microphone. If you just maybe you'd like to say who you are and where you're from.
Yes, my name is Karen Conway. I'm actually from the United States. You probably can tell. And I serve on the GS1 Global Healthcare Leadership Team. I really appreciate the comments this morning, and you brought up several topics that I've been looking at as how they interrelate, particularly related to health disparities, chronic disease, and climate change. Both health disparities and climate change are increasing chronic disease. Chronic disease is one of the reasons that we have challenges, not just in the UK, but in many countries, in terms of our ability to take care of patients and the reason that we have long waiting and lack of access. So I've been looking at how do we look at those, much like the triple aim that I know that Richard, I read with interest a piece you wrote last week about focusing on the triple aim in the bill going through Parliament. I look at them as they're all interconnected, and we cannot work on each of them separately, given the fact that we spend the vast majority of our money, I think about 75% in the UK, on chronic disease. And just thoughts in terms of how do we look at this together in terms of addressing it as opposed to how we often approach it in silos.
Richard, do you want to say what the triple aim is and then address the question?
So, as part of moving away from the competitive model, what government thought actually is an American idea from IHI, is you need a kind of overriding purpose. Why are we all here? And the triple aim for the health service that will apply to all NHS bodies and indeed those others working in health and care is made up of 3 elements. And I'm paraphrasing legal speak now, but to focus on the quality of care that you provide, to look at the health of the population and the people that you serve, so outside of your own organisation, potentially working with others, and to do so effectively with value for money as efficiently as you can, so be a good steward of resources. And the change that we suggested to government was that they were clearer about inequalities in that, so that as you set out what the guiding light would be, is that you specifically clock that inequalities and reduction of inequalities should be part of that triple aim. So it's still a triple aim. It's not got a 4th limb, as they're called, but inequalities is being put into the first 2, so that every organisation needs to have regard to that in the work that they do. And it's part of trying to make sure that people kind of that there is a guiding light. So when boards are thinking, is it okay if I'm moving beyond my organisation and trying to work with others and provide services in the community, particularly on issues like chronic care? Well, the answer is yes, that is exactly your job. And it's to try and clear up, I think, some of the competing views that you get across health and care. I should say it's only just going into legislation as we speak.
Okay, thank you very much. Any other comments or questions? Andrew, Keith was emphasizing, you and I will have experienced that, I like that phrase, thickening the rule book, the endless exhortations to try harder, more and more mandatory training, which is the bane of my fire extinguishers and all of the things we have to do. Getting technological solutions or engineered solutions or digital solutions to make healthcare safer, do you think NHS staff are a problem? Are they resistant to that? In your experience, are they the problem, or what do you think? Why is it not coming in faster?
Okay, so I did a couple of meetings recently. Been talking about some pretty important topics. One of them was climate change. One of them was obesity. And one of the suggestions was that we need to get mandatory training for NHS staff on these issues. And whilst I agree that we need to really upskill, up-knowledge people about this, I'm not sure mandatory training as it stands within the NHS is a way to do that. I leave my mandatory training to the last possible minute because it has become, everything is online, everything feels very much the same, and it feels very much like a tick box. And particularly when the quizzes at the end bear no relationship to the material you've just been flicking through for the past half an hour. So I think we have to be imaginative because I think safety is something that people feel passionately about. But how do you upskill people in that in a way that engages with them and doesn't turn them off? At the moment, mandatory e-training turns people off. So we've got to think, and I think we have to move back more towards a more interactive model. I know that's more expensive. And it might potentially be more time-consuming, but it's likely to be more effective in the long run. We are relational human beings. We like to relate to people. We will, I will remember more about a conversation I've had with you than a textbook that I will have read a chapter of. And I think we have to think like that. I also think that data is really important, and having some personalisation of that data. And you and I were talking beforehand. So as a colonoscopist, everything I do is recorded on the National Endoscopy Database. And I can bring up my KPIs of what I'm doing compared to everybody else in the department. And that's really powerful. And that really improves, that's a good way to improve my performance. And I feel it's personal to me, and I don't want to be that dot down there, I want to be that dot up there. And it's how do you then sort of personalise what people can do to improve patient safety. And data is the key to that.
And clinicians are pretty competitive people. If you saw yourself on that league table low down, most people would want to do better. Do you think that information should be something that's shared with the public? Should they be able to see if I'm going for a colonoscopy in Derby, that Dr. Goddard, Professor Goddard's there, and somebody, or do you think that's got its own problems?
It's hard because if you make data too transparent, then what happens is people will change their behaviours. Now, you want them to change them in a way that improves patient care, but the danger actually is that people may stop doing stuff. The reason that somebody may have a higher complication rate for a procedure is because they're operating on older, sicker, frailer, more multi-morbid patients, and who are more likely to have complications. And you don't want people saying, well, I'm not going to do that on them. I'm afraid this is too risky. And in that explanation of consent, in that consent process, I can say, well, this could help you, but it's a really dangerous procedure. Most of us as doctors, when we're consenting patients, we will put a bit of a spin on it, depending on how we think, it's going to go. And I think that it's very hard to look at a raw funnel plot, because that doesn't have the case mix bit in it. So I think there are dangers to that. However, I do think we need to be more transparent, and you can do that in an anonymised way to reassure people that we're looking at these things, what the norm is, but that there is a chance, depending on the other things, that you may not be at that level.
Duncan, there's a microphone coming.
Sorry to make you run. We've seen Duncan Eaton, I chair now GS1's Healthcare Advisory Board. We're seeing now more and more doctors coming into management, something that was virtually unknown in the days when I was more active managerially. Are we seeing improvements, changes as a result of that generally, but specifically in the attention that's given to safety in healthcare?
Richard, I mean, the US for a long time has had a long tradition of chief executives of hospitals being clinicians or medically qualified or senior nurses. As Doug said, relatively new in the NHS. Do you have any observations on, is that making an impact?
So some of the best providers in the States have definitely come from a world where the doctors are the managers, or clinicians are managers, perhaps, rather than doctors. And we do have some great examples in England, again, from the clinical community. So the head of Devon is ex-physio, we've got former nurses as chief executives, and it clearly changes the way that they can engage with staff. I think, I'll put it slightly around the other way, I think for a well-run organisation, if you don't have the engagement of staff, or you're not a well-run organisation, you can't be. Does that mean to say that you need clinicians in those management roles, the formal management roles? I'm not so sure that the evidence is so clear-cut that that's the case, despite some of the really amazing successes in some of the American providers. But that engagement with senior clinicians, absolutely. If you haven't got that, whatever their job title is, then that is a real issue. And that has been a recurrent problem in England, particularly in providers where, for one reason or another, their leadership has been moved on repeatedly. So, you know, for particular providers that struggle, they have a very rapid turnover of the executive team. That clearly does not work. And that does not lead you to engage between clinicians and the management community. That is a pretty good way of making sure things don't improve. And that's a real problem, and it goes back to safety as well, is that just moving people on every 3 months isn't a success. And so I think there's some key things about what makes leadership work, and I think having an engaged senior clinicians is absolutely key, but you just want good leaders, I think.
Any other comment? One at the back there, please, sorry.
Thank you. My name is Ed Polpham, and I work in the Chief Medical Officer's Unit of Scottish Government and also for NHS Supply Chain. So my question is around health inequalities, and particularly, I suppose, is it fair to say that some of the levers we as a society are going to have to pull to address health inequalities actually sit external from what we would call a traditional health and care system? Things like housing, workforce, standards of living. And then as a follow-up question, to what extent is the system set up today to be able to pull those levers across governments, devolved administrations, etc., to be able to influence that?
So we've been hearing a lot this morning about hospitals and GPs. So Michael Marmot would say 90% of health is determined by these social determinants, education, housing. Richard, Andrew, you start.
I mean, completely. So my college convened the Inequalities in Health Alliance to try and get lots of different parts of the health and care sector working together to sort of united lobbying, if you like. And our main call was for a cross-governmental approach. So that's, you know, across all sectors of the government, so education, housing, rural, education is really important. And every time I write to our Prime Minister to say this is what we found, this is what we're showing, it gets passed down to the Department of Health. It gets lost in the Department of Health for a bit, and then eventually a junior minister will reply. And I think there is, you know, we all know, and that's why I talked about the Black Report, and Michael Marmot's work is exactly the same. We know that this is a societal issue. This is not a purely health issue. You know, the reason that people live in very polluted streets is because they can't afford to live anywhere else. The reason that people are living with obesity is because They haven't got easy access to high quality, cheap food. And people make life choices based on what is available to them. And the levelling up agenda is good to hear, and they're talking about health disparities, and people are now, we're going to have the Office for Health Improvement and Disparities. We're a bit unclear how exactly that's going to work. There is the Prime Minister has set up a task force for this, and obviously under Michael Gove we have the whole of the levelling up agenda. But it needs some pretty hard work, and we need to do a lot of investment in those parts of our society, and it's a generational, two-generational process to really make a big impact. Because I can patch somebody up if they come onto my ward, but if somebody comes in with an exacerbation of asthma, but if they go back and they're living next to the M1, and all they're breathing in is diesel fumes, their asthma is going to come back. And therefore I need the government and the local government to set air pollution standards that people are held to account to stop that happening. So it's a completely cross-societal thing, and if we focus too much on health, we'll just not succeed.
You want to add, Rich?
Yeah, I mean, it's been exactly as Andrew said, a real challenge over the years for the Department of Health not to use the enormous sledgehammer it's got by its side, which is the NHS, and have a go at using healthcare to overcome inequalities. And of course, the whole setup of the NHS in the United Kingdom has a very strong equity element in it, which is you don't pay at the point of use. And just to be clear, across the world, that does mean people find it easier to access health services. I think you need to make sure the health service is there. There are some things that really influence disparities. CVD is one, where actually the interventions are pretty cheap and they're not difficult to do, as long as you find the people that need them. Then broader issues, air quality, many of the cancers, that it doesn't work so well for those. The bits, I think, history has told us how to do some of this. So it's great that we've got stop smoking services that have helped people to give up the use of tobacco. But you know what? We didn't have to tax them and regulate them as well to make it increasingly difficult either to access or to pay for tobacco. And so there's a whole other raft of tools that sit in Her Majesty's Treasury that I think, to be an optimist, they've put a tax on sugary drinks. So for the first time, a government is beginning to use taxation to think about the ways it can change people's behaviours. Away from Whitehall, I think one of the things in the reforms, which is, one hopes is optimistic, is these integrated care systems do bring local government and the NHS around the table in every part of the country, often with the voluntary sector, who often know the communities that suffer these disparities much better than the statutory services do, far more, much better advocates at understanding what works. And there's the hope that then, at least at those local levels, you can try and get some of that cooperation going. It's trickier once you reach Whitehall to get another government department to think, hang on a minute, this is health, isn't this Sajid's problem, not mine? And to actually get that health agenda there. Of course, by keeping the workforce healthy does actually help the economy as well. But
so if I could just one last thing. So the vaccination programme showed us that if you use local communities to engage with those populations, they will do so much more effectively than we as a wider system can. And therefore we do have to, I think with the ICS structure, we do have an opportunity to far better engage with local community and local community leaders to improve the health of those populations.
So I haven't forgotten your coffee break. The producer, Tim, gave me a note to say we could extend by 5 minutes. So you will be coming back at 10:40. I wanted to give the last question to Keith Conradi. When HSIB was being set up, there was a lot of feeling that doctors and nurses, clinicians, be more honest if they were immune from prosecution. And certainly, there was an idea that somehow in aviation there was this no blame culture. I went to British Airways, talked to some pilots, and they said, if you flew over your daughter's garden on her birthday and you waggled your wings, you'd be sacked. They said that's nonsense that aviation has a no-blame culture. People will be sanctioned. But I wonder if, Keith, you want to say something about that kind of urban myth about the difference between aviation and healthcare?
having been court-martialed for illegal low flying, I'm probably can speak with a little bit of experience, but it is a myth, and we don't use the phrase no blame. We might use fair blame or just culture, but we recognise that actually for the vast majority who are doing things in the best of spirits and attempting to do a great job, there will be some who are deliberately circumventing the rules for their own gain.
Yeah.
And we are required, and it is in the new bill, to actually make that known to the appropriate authority. And it did work the same in aviation. You know, if pilots come in and they're drunk or they've been drinking, absolutely the book needs to be thrown at them. And so there is a place for it, but I think the idea of having this area where people can come and speak candidly is not that they can confess. It is actually to talk about things that might be difficult from, if you like, a job security, you know, to talk about the difficulties with rostering, fatigue, management, and those things. And in all our experience, that's what people come and tell us. They're not come here on a confessional. It doesn't happen.
I wonder if you can join me in thanking a really brilliant session, our three panellists. Thank you very much.